My name is Blaine, as mentioned. I'm a faculty member at the School of Medicine. I'm a practicing internist, and I also see patients in the emergency department. I work for IU, as I mentioned, and Regan Street Institute. So disclosures, the work we're presenting today was funded by the American Medical Association, as well as the Regan Street Institute. I don't work for the AMA, but I do want to mention that it's interesting that the work funded by the talk we're talking about was under a program called Accelerating Change in Medical Education. So for those not in the US, the idea was there's a gap between what medical students are traditionally taught and the skill set they'll need as a resident or as a independent practitioner. And how can we use innovative ways to close that gap in medical education? Well, this thing is. And then the Regan Street Institute is a support organization for the Indiana School of Medicine. And we received funding from the Regan Street Foundation for this work, because as soon as we started to talk about our project, other schools expressed interest, and we had to switch from a research platform to a scalable, generalizable platform that could be used for schools outside of IU. So the format of the talk is to talk about some of the themes that have been brought up by previous speakers, and then talk about our specific small little solution for some of these problems. So if you look at, it's mentioned by many of the speakers in terms of improved care, moving forward, it's all about data, right? We have massive amounts of data, and how do we manage that data? Mostly people would argue it'll be through information technology. And here's some examples of that data, To get to that, before that, I bet you most of you did not know that Sir Conan Doyle was a data scientist. But if you look at this quote from Sherlock Holmes, "It is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit the facts." So, that's what a typical data scientist would say. So in 2015, it was estimated that 30% of all the world's digitized data was healthcare. And if you think about the ginormous aspects of data, in the US, it's estimated that every patient will produce about 80 gigabytes of data per year. That's images and records and EHRs, and as Daniel mentioned, Fitbits, things like that. And in 2015, there was 25,000 petabytes of data around genomics, and that was doubling every 7 months. So this really scares me as a clinician and as a data scientist, because how are we going to manage that and translate all this data into practical care? And that's on the patient side. How about the knowledge side? This is a paper by Bill Stead out of Vanderbilt. Sorry, controls issues. Where he estimated that it takes 5 facts to make a decision clinically. And at the rate of generation of genomic data, that by around this time, 2018, that we will have enough genomic data that's beyond human capacity to synthesize and be able to come up with a decision, right? So from 2018 on, we're in big trouble, right, if we try to do it on our own. This is a slide from clinicaltrials.gov, and again, shows on the knowledge side the number of studies that have been published in literature across the country and across the world. And I use this as a surrogate for the amount of knowledge on the therapy side and how we're trying to apply to patient care. There was an article last year that you may have seen from the Annals of Internal Medicine. There's 11 organizations that had 104, I believe, guidelines on how to treat, prevent, and diagnose hypertension. I don't know how clinician is supposed to do that in a 15-minute visit and address all the other issues they have to address. So it really is up to information technology, and we started slow, right? We started low. So our project we developed at Indiana was using an electronic health record to help our students learn about electronic health records. And unbeknownst to me at the time, because I was not involved in medical education at the time, there are many, many medical schools across the United States that do not allow their students to have meaningful access to their EHRs. Come as a shock, right? Because on the first day of residency, these kids have to get onto the computer and put in their orders and write their notes and take care of patients. Well, if they don't know how to do that, I'm not sure when they're supposed to get that training, because they're trying to also learn how to be independent practitioners. So we developed a platform. Fortunately, we had a lot of experience at Regan Street. This is a branch of an EHR that's been around for about 40 years. We branched off this project to support curricular instead of clinical ideas. We have about 12,000 patients associated with this EHR. They're all pseudo-nominized. So what that means is all patient identifiers and provider identifiers are scrubbed, and they're substituted with fake names. Now, being naive, when we first applied for the grant, we thought we'd have to go through 600-700 medical records, and we would hire medical students to scrub those text reports. Well, it turned out for our first lesson at IU, we had identified 384 patients. Those 384 patients generated 33,000 text reports in 1 year. So doing that manually was not scalable. So it took us about 2 years to develop an automated way to scrub those records. And that turned out to be fortuitous, because our health system now allows us to use these patients for medical schools and nursing schools and pharmacy schools where there's no business agreement. So we get around the HIPAA restrictions there. So when we started the project, we thought, this is cool. Okay, we'll teach kids how to use an EHR. We can potentially use innovative ways through decision support to generate instruction or educational vignettes. But again, when you think about data and how we're going to manage that data, this is not good enough, right? So we thought this was pretty good, and we're all proud of ourselves. But again, if you think about the data, this is not sufficient. So the reason why it's called a platform is because there's other functionalities within the system that we use. So we have a patient list generator. So this was generated by one of my frustrations, in that medication got black boxed by the FDA. So for the folks outside the United States, again, black box means you shouldn't prescribe it unless you really need to. And I asked my decision support team on another EHR, a commercial EHR, to come up with a list of patients that were on that medication, so we could send a notification saying, hey, this is not safe, you shouldn't be on this, and come in and we'll talk about making a substitution. Well, I got a list, and there were patients on the list that were not on the medication, and then I had patients roll into the clinic 3 months later, not on the list, that were on the medication. So I just didn't get it, right? It's like that movie, Tom Hanks and Biggs. I don't get it. So we created this patient list generator for me, and I'm selfish, but the idea was to have a sub-second query tool where you didn't have to be a database expert, but you could create sophisticated queries. So through the database, you can see there's about 3 million patients in this database. You can look at diagnoses and medications and demographics and encounters. So if you want to look at all the patients who are over 55, who have diabetes, that have at least 5 emergency department visits, you can do this. And again, you don't have to have any kind of coding experience to do that, although it's being used for education of students in those respects, right? Because if you look at this slide, you can see there are coding terms. So ICD-9 and ICD-10 terms, and that's a valuable education to students, right? If you put in diabetes, that doesn't pull up all the patients with diabetes. You have to be pretty specific about what exactly you mean by diabetes. And the whole project wasn't to train people to become an informatician like me, but we know that a lot of our students will become service line chiefs. They'll be leaders at their site or leaders within their group, and they'll have to learn all these terms and these concepts because that's how you get paid, right? At least in the United States right now, it's paid for performance. So you have to know what metrics under which you're going to have to be paid. So we turned this tool from a tool that was facing clinicians to a tool that was used by educators to now the tool that our students are using. So the University of Connecticut used this tool to look at the number of women over 40 who had a mammogram ordered versus how many had a mammogram ordered and had one performed versus the number of women over 40 who never had a mammogram ordered. So you can think about this tool as a quality measure tool. You can use it for applied statistics, prevalence and incidence, and that kind of thing. Again, you can also learn the basic concepts on how these performance metrics are derived. The other aspect of the system we used is we were lucky that we ran, and Daniel talked about this, pharmacogenomics, right? We have a pharmacogenomics trial running at IU, so we were able to take some of these alerts that are fired around pharmacogenomics, and then again, for those folks that don't know, when a physician or a provider prescribes a medication to you, you may or may not respond to it based on your genomics, right? And up until recently, we really didn't know. The classic example was after a patient got a cardiac stent, was put on an antiplatelet medication, and a week later came back with a restenosis of that stent. Well, some cynical physicians said, well, the patient's not taking the medicine, right? But they are taking the medicine. They just can't metabolize it, or they're slow metabolizers of that medicine. And we've discovered that since. But if you think about this in terms of medical education, this is a great example, and we're running a trial on this year at IU of using a clinical case to bring in some of the basic sciences, right? So around pharmacogenomics, it's a pharmacology lecture, it's a genetics lecture, it's a biochemistry lecture, it's a physiology lecture. So the hope is that using genomics, at least, that we can bring clinical relevance into the basic sciences and vice versa. And finally, we also have a piece that's being used for interprofessional education. So as we've heard from multiple speakers before, moving forward, healthcare would be a team sport. It won't be the physician or the PA or the NP as the captain of the ship. So we had functionality within our clinical system that allowed multiple people on the same chart at the same time. So if you go into most commercial systems, if I log in and somebody else tries to log in to that same patient, you get blocked, right? But being at an academic medical center, we have a resident, a couple of interns, 4 or 5 medical students, maybe a couple of nursing students, a pharmacy student, all rotating around, and we didn't think it was very efficient to block other people out of the EHR. So we created this functionality with the system that allows people to be in the system at the same time and be notified for how other members of the teams are interacting with that patient. So I can order a medication, and if somebody else on my team tries to order the same medication, alert fires, and this is what you see here. But if you think about it, this allows for interprofessional education. So you could have a nursing student in the lobby of the nursing school on the same patient at the same time as a medical student in his apartment and a pharmacy student sitting in a classroom. And that's actually how it's being used. We have a pharmacy school in a different city and a nursing school in a different city than our medical school, and they're all getting together, working through cases either simultaneously, we call it synchronously, so they're on the system at the same time, or asynchronously, so they all do their work, but they can see what each other has been doing. Finally, a big piece of the platform which we did not recognize early on, was the ability to evaluate our students. So the idea is as they move through, as they put in orders in for medication, IV, consults, that the system would automatically score the students as they work through the case. IU has 9 campuses. I think we're the biggest medical school now in the country. And, and sometimes, and a lot of our faculty are 100% clinicians, right? So they out of the generosity of their heart, provide education for our students. But sometimes what that meant was the students weren't getting evaluation in a timely manner. But so being able to create a way to automate a student as they move through exercise has proven to be valuable, not only for students because they get immediate feedback, but also for our faculty because they don't have to take the time to evaluate the students. Well, one of the future things we're working on right now is automating the scoring of history and physicals. So you heard about machine learning. This is kind of a machine learning approach to looking at whether we can judge whether a student is running an adequate note or a poor note. It's too early to tell since we just kicked off this project right before I left. And finally, a couple more, I shouldn't say finally, a couple more slides. This slide, is meant to show that since it's EHR and we keep all the actions of our students within the EHR, then you can use it as a way for formative assessment as students as they matriculate through a medical school. So you can ask them the same question in their first year, their second year, their fourth year, and see if there's any progression in their ability to answer that question, that clinical question. And what we found, not surprising to you all, I'm sure, is that that you cannot present the same patient to a first-year medical student and versus a fourth-year medical student, because a first-year medical student does not have the clinical experience to know what's important within a medical record versus hopefully a fourth-year student does. We found that, for example, we had a patient who the idea was not to prescribe antibiotics because of overprescription of antibiotics is a big problem in the United States. Well, the patient happened to be on Coumadin. And there were INRs that were measuring the effectiveness of Coumadin, which is an anticoagulation medication. And the students got all bent out of shape. They were looking at what an INR means and what affects the INR, and actually that wasn't even the point of the lesson. So we learned from that experience that you have to really call down a medical record for a first-year medical student, whereas again, third-year and fourth-year medical students, you don't have to. Where are we moving in the future? So in the future, right now, we're working on something called gamification. So the example I always use, and when my kids were young, they had a video game. They knew they had to jump over the fence, push the rabbit aside and jump into the barn before they moved to the second level. Well, if you think about it in terms of learning how to use the medical record, potentially that's a way we could teach our students to move efficiently through a medical record. You've heard about burnout. Medical EHRs are generally cited as one of the reasons for burnout, but if we can teach students early on in their training how to move through a medical record efficiently, then hopefully that will result in less burnout. And finally, if communication is a measure of impact, this is a slide that shows all the schools that we've talked to about using the system. Most of them are medical schools. They're in blue. Some of them have no medical schools associated with them, and they're in orange. Some are companies like Google and Figure One. They're in yellow. Some are professional organizations like the National Library of Medicine. I'm not sure why Duke is in red, sorry. But the ACP, ACR. And then we also have international schools. So some schools send their students to the United States either for residency or they finish up They actually work in the United States, but they have no access to American patients. And so they show interest there. So that's it. Any questions? I guess we're taking questions later, sorry. Thank you.